In this lecture, we will discuss sexual disorders and dysfunctions. The human sexual response cycle consists of 4 phases: desire, excitement, orgasm, and resolution. Depending on the researchers cited, these phases may include excitement, plateau, orgasm, and resolution. Sexual dysfunctions, disorders in which people cannot respond normally in a key area of sexual functioning, make it difficult or impossible for a person to have or enjoy sexual activity. Studies suggest that as many as 30% of men and 45% of women around the world suffer from such a dysfunction during their lives. Sexual dysfunctions are typically very distressing, and they can often lead to sexual frustration, guilt, loss of self-esteem, and interpersonal problems. Some people struggle with a sexual dysfunction their whole lives. In other cases, normal sexual functioning precedes the dysfunction, and in some other cases, the dysfunction is present during all sexual situations, and in others, it is tied to a particular situation. So let's start off with disorders of desire. The desire phase of the sexual response cycle consists of an interest in or urge to have sex, sexual attraction to others, and for many people, sexual fantasies. 2 dysfunctions affect the desire phase: male hypoactive sexual desire disorder and female sexual interest arousal disorder. The latter disorder actually cuts across both of the desire and excitement phases of the sexual response cycle. It is considered a single disorder in the DSM-5 because, according to research, desire and arousal overlap particularly highly for women, and many women express difficulty distinguishing feelings of desire from those of arousal. A number of people have normal sexual interests but choose, as a matter of lifestyle rather than sexual desire, to avoid engaging in sexual relations. These people may not be diagnosed as having one of these sexual desire disorders. Men with male hyposexual desire disorder persistently lack or have reduced interest in sex and engage in little sexual activity. Nevertheless, when they do have sex, their physical responses may be normal and they may enjoy the experience. While most cultures portray men as wanting all the sex they can get, as many as 18% of men worldwide have this disorder, and the number seeking therapy has increased during the past decade. Women with female sexual interest arousal disorder also lack normal interest in sex and rarely initiate sexual activity. In addition, many such have few genital or non-genital sensations during sexual activity. As many as 39% of women worldwide have reduced sexual interest and arousal. It is important to note that many sex researchers and therapists believe it is inaccurate to combine desire and excitement symptoms into a single female disorder. They would have preferred that the DSM-5 continue the past DSM tradition of listing 2 separate dysfunctions: female hyperactive sexual desire disorder and female sexual arousal disorder. A person's sex drive is determined by a combination of biological, psychological, and sociocultural factors, any of which may reduce sexual desire. Most cases of low sexual desire are caused primarily by sociocultural and psychological factors, but biological conditions can also lower sex drive significantly. The excitement phase of the sexual response cycle is marked by changes in the pelvic region, general physical arousal, and increases a heart rate, muscle tension, blood pressure, and rate of breathing. In men, blood pools to the pelvis and leads to erection of the penis. In women, this phase produces swelling of the clitoris as well as lubrication of the vagina. Now, let us review erectile disorder. Men with erectile disorder persistently fail to attain or maintain an erection during sexual activity. This problem occurs in 15 to 25% of the male population. Most cases of erectile disorder result from an interaction of biological, psychological, and sociocultural processes. Now, let us quickly move on to disorders of orgasm. During the orgasm phase of the sexual response cycle, a person's sexual pleasure peaks and sexual tension is released as the muscles in the pelvic region contract or draw together in rhythms. The man's semen is ejaculated, and the outer third of the woman's vaginal walls contract. Dysfunctions of this phase of the sexual response cycle are early ejaculation and delayed ejaculation in men, and female orgasmic disorder in women. A man suffering from premature ejaculation, also called early or rapid ejaculation, persistently reaches orgasm and ejaculates within 1 minute of beginning sexual activity with a partner and before he wishes to do so. As many as 30% of men worldwide ejaculate early at some time. The typical duration of intercourse in our society has increased over the past decades, which has caused more distress among men who ejaculate prematurely. Although many young men certainly contend with the dysfunction, research suggests that men of any age may suffer from it. Now, a man with delayed ejaculation, previously called male orgasmic disorder, is unable to ejaculate or has a very delayed ejaculation during sexual activity with a partner. As many as 10% of men worldwide have this disorder. Women with female orgasmic disorder persistently fail to reach orgasm, have very low intensity orgasms, or have very delayed orgasms. Around 21% of women apparently experience this pattern of some degree. Studies indicate that 10% or more of women have never had an orgasm, either alone or during intercourse, and at least 9% rarely have orgasms. At the same time, 50 to 70% of all women experience orgasm in intercourse, at least fairly regularly. Women who are more sexually assertive and are comfortable with masturbation tend to have orgasms more regularly. Most clinicians agree that orgasm during intercourse is not mandatory for normal sexual functioning. Many women instead reach orgasm with their partners by direct stimulation of the clitoris. Although early psychoanalytic theory considered a lack of orgasm during intercourse to be pathological, evidence suggests that women who rely on stimulation of the clitoris for orgasm are entirely normal and healthy. It is important to note that a number of clinicians further believe that the achievement of orgasm under any circumstance is not a defining feature of an acceptable and normal sex life. Now, let us review disorders of sexual pain. Certain sexual dysfunctions are characterized by enormous physical discomfort during intercourse, a difficulty that does not fit neatly into specific part of the sexual response cycle. Women have such dysfunctions much more often than men do. For some women with this disorder, the muscles around the outer third of the vagina involuntarily contract, preventing entry of the penis. This problem can prevent a couple from ever having intercourse. Now let us review the treatments for sexual dysfunctions. In the 1970s, the work of William Masters and Virginia Johnson led to the development of sex therapy. Today, sex therapy combines a variety of cognitive, behavioral, couple, and family systems therapies. It generally includes features such as careful assessment, education, acceptance of mutual responsibility, attitude changes, improvements in communication, and couples therapy. In addition, specific techniques have been developed for each of the sexual dysfunctions. The use of biological treatments for sexual dysfunctions is also increasing. In another lecture, I will review paraphilic disorders. They are patterns characterized by recurrent and intensive sexual urges, fantasies, or behaviors involving objects or situations outside the usual sexual norms. For example, non-human objects, children, non-consenting adults, or experiences of suffering or humiliation.